and thanks to the Victorian Department of Health, Australian Therapeutic Goods Administration (TGA), and the Radiation Protection of Nuclear Safety Agency for their generous support of this webinar. I think their support is a testament to Australia and Indonesia cooperation in improving health of people in both our country. I think the webinar is a great opportunity for us to learn more about cyclotron and PET scan and their potential benefit for Indonesia. I believe this webinar will be highly beneficial to our country, as we will gain valuable knowledge and insight from experts from Australia, which has already pioneered to development of the technology. I believe that technology have the potential to improve the life for the million of Indonesian people. That concludes my address. Thank you very much for your support. Wassalamualaikum warahmatullahi wabarakatuh. Om Santi Santi Om. Thank you.
Terima kasih, Pak Hasan. So, thank you very much, Pak Hasan. So, he is not able to go to Australia because this is at the end of the year. So, everybody should be in Indonesia for special advisor for the minister. Thank you very much for this very good time for us to learn about cyclotron and also the PET scan. And today we had visited hospital, yes, back here, and also visited one clinics for PET scan. And this is one new experience for us because actually PET scan is only at the hospital in Indonesia, but here is also in the clinics. It's very, very interesting. Okay, so we are very eager to learn from your experience in how to manage the cancer and also the PET scan activities. Okay, thank you very much.
Thank you. I might have to call it.
Thanks for the opportunity to talk to you about our cancer plan. As Ewan indicated, we do have legislation here in Victoria where government has set out a range of focus, emphasise the focus that they want us to have on cancer and cancer control. So it includes things like planning, developing, coordinating, funding, promoting, supporting and enabling health services relating to cancer and cancer care, looking at cancer from the whole gamut of prevention, early detection, diagnosis and treatment of cancer, including and also the ongoing management of cancer and care for those affected. It requires us to have a continuous improvement focus and to also facilitate and support research into cancer and how we can improve cancer control. So they're all the things that are set out and are delegated to the department. The main responsibility rests with Ewan as the Secretary of the Department, but luckily he's got big shoulders and we are continuing to do this work. And also, as Ewan indicated, we must have a new cancer plan every 4 years where we look to set out what are the priorities, what are the actionable areas and the key directions for the coming years. They're copies that you can take with you, those, and I have in fact asked the office to bring down a few more since we have some extra people today. The current plan does follow that pathway as outlined in the Act, looking at primary prevention, screening and early detection, treatment, wellbeing and support, and also research. This is a fairly mature program in Australia, here in Victoria as well, because this is the third, it's actually the third plan, only two under the Act. There was a prior plan before that. Excellent. And the reason that there is a focus on cancer is because of the burden of the disease. I mean, Ewan's talked about the number of people that live in Victoria. So out of that population, every year there's nearly 35,000 new cancer diagnoses made in the Victorian population. And approximately 11,500 people die each year from their cancer. That represents about a third of all deaths in Victoria. So it is a significant burden on our community. I'm not sure what the situation is in your city, and I'd be interested in any epidemiological data that you might like to share, because here the average age of a person at the time of diagnosis is 67 years. So there is a large cohort of cancer patients who are elderly. It's also growing in numbers. By 2036, so it's an old slide, we do expect there to be about 51,000 new cancer diagnoses each year. And despite those figures, we do have very good survival comparatively to other jurisdictions. So we have overall currently our is about 5-year survival is 72%. We also know that there are a number of our cancers which could be prevented. So, for example, in breast, there is a proportion of those cancers which, with good screening and other behavioural changes, would be reduced. The same with things like bowel cancer, screening programs again, and diet. Lung cancer, obviously, smoking is one of those concerns there, and melanoma where there's sun exposure. The cancer related primarily hepatitis infections and liver cirrhosis. And cervical cancer again is reducing. We hope to have elimination because of our screening programs and also HPV vaccination. Excellent, thanks. So the cancer program within the department has 4 sort of key pillars at the moment. I've put cancer prevention and screening in a different colour because they actually sit separate from the area where we are. They sit within population health, and they are part of a national approach, some of which is actually embedded into primary care, cervical screening, and our cancer screening is supported by our GPs, so general practitioners. We have a cancer services and information section, which does a lot of the management and performance of things like radiotherapy, which is where Colin's expertise comes in. We also have a cancer policy and improvement area, which is the area that develops the major policy in terms of the cancer plan. We have one other group, which is called the Victorian Cancer Agency, which provides funding for research projects and also research fellowships to promote improved outcomes, to look at the translation of laboratory-based research into clinical practice, and with a focus on patient outcomes. So they're the sort of main areas. Again, within cancer services, as I said, we talked about it looks at the performance of our services. That covers chemotherapy, radiotherapy. We do have 2 very specialised statewide radiotherapy services, the MRI MINAC, which is only the 3rd in Australia, and also, unless there's been one open since, and Gamma Knife, which is also particularly useful for brain cancers. We have a statewide cancer registry, so all new cancer diagnoses are captured in that population-based register. It is used for us monitoring the impacts and the burden of cancer. It also obviously supports research as a sampling frame, and it does feed into a lot of the work that we do. The other data set there is the Victorian Radiotherapy Minimum Data Set, so we do capture a lot of information there. And we are building up a statewide multidisciplinary team meeting data set so that we can actually understand those people who have been to an MDM and had discussions about treatment options, capturing things like disease stage and functional status of the patients, which influences decisions on medical treatments in those individuals. They may be offered. One of the other things that we do have in Victoria and nationally that have been adopted are the optimal care pathways, which go from prevention right through to end of life, identifying some of the key things that you might need to look for, you might need to do in terms of diagnostics, what's the preferred treatment, and also talks about supportive care as well. Talks about the treatment team. And there are about 25 of these for different cancers. So it covers, in this instance, breast cancer, but also blood cancers. It covers things like prostate cancer, a whole range of cancers. And as I said, they have been endorsed at the national level by health ministers, and they are for adoption within jurisdictions. They're also going to be a central underpinning of the recently released Australian Cancer Plan, which was released last week at the National Scientific Meeting for Cancer. And those are publicly available. You can have a look at those. They may be of some assistance in looking at your own systems for cancer. There is also a version which is for individuals, for the patient and their carers, so that they can understand what to expect, their guides to best care, and they're also freely available on that website. There are 7 languages. Unfortunately, I don't think there's Indonesian, but there are a range of other languages available. Next slide, please. In terms of cancer services, as you indicated, the majority of our population is based in metropolitan Melbourne, but we do have some key centres outside of that. And although there are 73 health services, I think you said, not all of those will offer cancer services. Probably the chemotherapy is more distributed because that can be delivered under supervision of a higher level service where they might have a medical oncologist or a haematologist, and then nursing delivering the local care. Radiotherapy is located at our main centres. In a couple of instances, because of the restrictions at the federal level on the number of linear accelerators that can be located to service a population base, we have had to enter into public-private arrangements for access to a private facility if it's already in place. We do have a good distribution of diagnostic imaging. Up there, we've noted that there's 85 magnetic resonance imaging machines across the state, as well as 21 PET machines. Not all of those are public, but there is a good distribution of that technology. There's only 2 public cyclotrons we were talking about earlier that are at Austin Health and Betamax, so you will be visiting both of those sites and no doubt see that equipment that's available. We have a strong focus too on offering clinical trials to patients, and we know that regional patients, those who are away from the city centres, are less likely to be offered a clinical trial, and we're trying to address that through support for regional trials centres and also the use of teletrials, so telehealth, to conduct clinical trials. And we are also at the moment looking at service capability frameworks, which is really a guidance about the sorts of supports and technology that you need to have in place to deliver treatments of a certain type. So a level 6 service is providing very complex care, perhaps to rarer cancers with high-tech equipment or offerings in terms of treatment. So Peter McCallum is obviously a level 6, right down to sort of lower level services that, as I described, might simply be providing chemotherapy to patients at a local level, with fairly safe standard protocols. And I also mentioned the two linear accelerators that we have, which are statewide services, because they're providing very complex and very expensive bit of kit. And we do have some low volume surgery where we do have a bit of centralisation of that, again, from a safety and quality point of view.
Apologies, I need to, but yeah, again, thank you for visiting.
Yeah.
Thanks.
And that's actually my last slide. Yeah. So perfect timing. And I welcome any. We both welcome any questions and any comments you'd like to share about your jurisdiction. But I might just ask Colin to kick us off by talking a little bit about radiation safety and how that's managed here in Victoria.
In Victoria, whether you have a sealed source or an unsealed source, and whether it's electrically produced as in a linear accelerator or a superficial machine, or it's a radioactive isotope might be used in a PET scanner, that's all regulated by the state. So the jurisdictions handle regulation in our country. So your DG mentioned that you had some sponsorship of the Australian Radiation Protection and Nuclear Safety Agency. They don't manage the regulation of the actual sources in a jurisdiction. Our government does through a regulatory authority. And that's really important because they set the safety standards for the use of radiation, whether it be medical imaging or treatment, and you need to comply with their standards. So we have a great program of ensuring that linear accelerators get an independent audit for anyone who's treated on them. Similarly, the regulatory authority would look at a PET facility and ensure that not only is the scanner in an appropriate enclosure, but things like uptake rooms and so on are also appropriately shielded. And is there a radiation safe? What's the pathway for delivery? All those sort of things. So from the point of view of radiation utilisation in health, it's an end-to-end safety process. And even in private facilities, they're subject to that because we have a number of private PET scanners and treatment facilities. They are subject to the same regulations. And private facilities are also subject to a review by our private hospitals area in terms of the department design and layout. So while they're not responsible for the radiation, there is an interplay between who might be inadvertently irradiated by the design of the facility. So we work collaboratively with those three areas to ensure that any kind of treatment or medical scan is delivered in a safe environment and safely. So that's, and the other thing is Gamma Knife, of course, is not a linear accelerator. That is a sealed source, and there are 192 of them in that machine. So there's a whole piece of regulation that covers off delivery of those sources and what happens to the old sources. So the state is very conscious of the fact that if you're delivering safe healthcare, you've got to look after the before, during and after side of the radiation.
The only other comment I might make too is that you did touch on the fact that we have a federal system and a state system, and some of the funding that we rely on is where the Medicare benefits schedule this something for payment under the national program, and same for pharmaceutical medications. So we things like our PET, we limit ourselves in many respects to those indications that are funded under the MBS, and that sort of is the range of the scope of activity. There are also limitations to, I guess, on some aspects of this. I note that you are meeting with the Therapeutics Authority because they do have a role to play in that sort of national safety frame. And so some of the work that we've been doing in the area of radiopharmaceuticals work is in the research part of the program. And with the packs that are on the tables, there is a list of some of the work that we have funded that health sector is doing in clinical trials and other research things which some of it is more on the imaging side, but some is definitely on the radiopharmaceutical treatment side, particularly with the focus on prostate cancer.
Would you like to ask any questions, or is there anything you'd like to share?
Which we will try to answer.
One question from my meeting. So because he has to go to another meeting,
Yes.
but he has something about yes, about the proton beam therapy in cancer. Is there any development here and how to finance it?
How diplomatically to say this? We have the government did develop a business case, and there is one proton beam therapy centre being established at the Bragg Centre.
The Australian Bragg Centre, which is
In
the
South
proton
Australia.
centre in South Australia.
South Australia. Yes, in Adelaide, and it will be the first one. It is partly experimental research, one line, and there's a couple of treatment groups from recollection. So that's going to be the first one in Australia. We did a business case here in Victoria, and it's obviously expensive, so we did ask the Commonwealth Government if they would co-contribute financially. They declined the opportunity, and so we are waiting to see. There has been an announcement that Queensland in Brisbane, at the Royal Brisbane Hospital, they will be pursuing a proton beam therapy service there, but that's still in the planning stage. Cancer Australia. So when I mentioned the federal government before, I should explain that sort of outside but aligned to the federal government and fully funded by the federal government is the Cancer Australia agency, and it has a role in it. It is the agency that has developed the Australian Cancer Plan, which I mentioned was released last week. They have just produced a policy document about proton beam for Australia. I don't know whether it's entirely finalised. They did have a roundtable with everybody from Australia, clinicians and policymakers, to agree what might be the way forward, because obviously with our population, even at the national level, there's only probably 3 centres that we would need over the next couple of decades. In that policy document, they did not list Victoria as a number 1, unfortunately, but we are responding because that's actually very recently released.
It's a work in progress.
Yes, I think so.
Apart from the business cases, Victoria has actually invested some money in proton therapy through a training program. So we have actually had some people trained in proton therapy planning because there is a national program through the Commonwealth Government for funding people to go overseas and get proton treatment. And one of the requirements of that funding is that protons have to be proven to be better as a treatment option for that patient than what would be delivered locally in Australia. So we have the ability in our state to actually develop a proton plan and a standard LINAC-based plan, so from a, which can be treated on any LINAC accelerator, and show whether there's an advantage to the Commonwealth funding to leave the country. The other thing that's probably worth just mentioning, the centre in Adelaide is a private centre, not a public centre. So as is happens in other countries, sometimes the private develop the first one. So that happened in Singapore, for example.
So in terms of the planning, we did sponsor some people from Peter McCallum to go to somewhere in the US.
No, the US came to Australia and we had 5 people trained.
Yep, good.
So not already in private financing.
That's in Adelaide. In Victoria, it's public. So we've funded through the Peter Mac, through the public systems, proton planning training. We actually have a national consortium of jurisdictions who get together to compare plans and support each other, because Royal Brisbane's proposed proton facility will be part of a bigger comprehensive cancer centre up there. They're building it in as they go.
So I guess one of the things is it's an evidence-based way of trying to understand the potential benefits of proton beam. So that's built that into a future business case as well.
not yet written here, or already?
It's not specifically
Oh.
mentioned in there, no.
No, the business cases where we put together details about the benefits and the costs, and then government considers those costs and the benefits and decides whether to fund that from Treasury. And as I said, it was expensive, so that we would have required Commonwealth contribution funding, which is not unusual. Like when you've been to Macallan, you see the beautiful building. The federal government contributed quite a lot of money to help that.
I think one of the things that Peter Mack, radiation oncologists, are thinking about is the advancements in technology around the proton therapy, kind of the location, how big a space it needs, also the technology such that in 3 or 4 years' time, the footprint might be much less and also much cheaper. So there may actually be an advantage of not being the first one to make the largest investment on a national basis. So that's closely following. I think there's some companies out of Israel that are putting smaller footprint machines and thinking about what that might do for clinical services, but also the research opportunities that are associated with that type of being able to provide that service as well.
So we haven't lost hope of ever having a project, but it's not something that we're immediately.
Name Gustavo. I am from Gajah Mada University, namely from the Department of Nuclear Engineering. I would like to know about this program, the clinical trial and tele trial. What is this?
It's mainly pharmaceuticals, and it's where you have a sponsored trial, and the sponsor may be linked directly to Peter MacCallum, but rather than have the patients all come into MacCallum for their clinical trial protocol, delivery of their medications and their follow-up imagings and whatever it might be, blood tests, they actually remain perhaps in Bendigo, Swan Hill, wherever it might be, and there's a telehealth link with their treating practitioners at the local area to make it more accessible to those patients.
On that map there, you can see a little dot to the far left, and that's called Warrnambool. There was a stage 3 lung cancer trial that they were credentialed for in conjunction with working with Peter Mack to deliver some local radiotherapy there. So that's the sort of thing where you can support it. They still needed to be credentialed, but the hub, if you like, of the big state cancer centre supported the local people in getting that up. It was a combination of medical oncology and radiotherapy. So it can be delivered remotely with some safety where there's that oversight.
Because otherwise, probably in your terms of distances, it's probably not that far, but it's still a 3.5-hour drive, 4-hour drive for those patients. And often, in some studies, you need to stay locally for a period of time, so they're away from their family and their surgeons. They're also using teletrials in Queensland very successfully, where there are much greater distances, to Mount Isa or wherever it might be.
Back a long way away, isn't it? Meg, was there anything you wanted to say on Someone wants to ask a
That should be
question
better.
online.
Yeah, that should be better.
We see if anyone's literally just saw a little yellow hand appear. Use time to be vigilant.
Comment that I think we got on mute, so whether that was also part of it.
Oh, just a question in reference to radiation safety. It'd be handy to actually understand a little bit more detail about how the Department of Health handles facilities and personnel, both nuclear technologists and, you know, I'm from Cyclotech, so we have our own staff that have a radiation protection. It might be handy to give a little bit more detail around how that process works.
We'll start with the staff. That's a pretty straightforward one. So everybody who works in the radiation field, whether it be with sealed sources or machinery that produces radiation, must wear a film badge. So in our state, it's a requirement for staff to have that, and they're assessed quarterly for a radiation dose. And over the course of a year, there's the international standards that we follow that an exposed person cannot get more than that amount. But long before they get there, the quarterly report would flag if there was a pending issue, and they would be investigated. So every health service that has a radiation exposing machine or treatment facility has a radiation safety officer. That's also part of our regulation as well. So that person is responsible for overseeing film badge dose and distribution and return, and they make sure that that's done. From the, what was the second
Facility.
Oh, the facilities.
Compared to cyclotron.
Yeah. So our regulator is the person or the group that looks after the facility itself. So before a facility can actually operate, it has to have dose measurements done. So there, obviously, when you plan them, there's calculations around expected doses to certain areas. But then once the facility is actually built, that must be tested. So the actual equipment is used, the radiation sources are put there, and then there's actually repeated dose measurements done. The regulator actually does that as part of their role in terms of measuring the outcomes of that and ensuring that nothing exceeds the planned dose and where it goes. So that's a requirement of actually instigating any facility in our state.
Oh, and is there any qualifications for attaining a radiation license? I know in New South Wales EPA you have to be you have to have a science degree. It's stipulated.
No, not like that. Well, the qualifications relate to it's an interplay between licensing and because there's licensing of the actual practitioners as well and the facility itself. But the regulator in particular is interested in the facility itself and making sure that that facility delivers on its planned doses, and there must be calculations from qualified people. So they will actually cite that and ensure that the actual plan, because there might be some unexpected circumstance, and most calculations are done very conservatively. Those of you in radiation will know that. So we try and aim for 1/10 of the international limit of dose, annual dose, to occupationally exposed workers to ensure that kind of margin is built in. But they do pay attention to ensuring that the facility itself will, the calculation will agree with the measurement, but the calculation itself, they pay attention to who did it, what's their qualification and background and expertise to make sure that they are appropriately qualified. So we only have a few providers of that service. They're usually qualified medical physicists.
Just taking that safety message a bit further though, so we also have, if you like, simulated exercises. So should there be a breach, so radiation exposure or chemical event, at a local level teams practice on how to respond and how to contain and maintain safety, but also at a state level, our state emergency management team also have run scenarios should we have a significant event in the state. We have to manage radiation safety at a bigger scale. So there's many layers to the safety question actually.
It's an extension of Greg's comment about you talking about the infrastructure, you put in the cyclotrons and scanners. Do you have a broad brush then of the adoption of the technology into the clinical care pathways, training of medical staff, so that they don't sit there idle. Those utility infrastructures that are utilised. Would you have a broad brush view of how the department over the years introduces new technology in terms of training and upskilling?
I think it's a complex picture.
Yeah, I agree.
Because obviously there's the federal approval of technologies. There's the federal consideration of cost benefit and funding. And then there's also, I guess, at the state, sort of the service planning component of what we're for particular populations. And then on top of that, there's the role of relevant colleges or professional organisations in supporting or promoting relevant training. So yeah, we'll talk about that one at length some of the time.
Broadly, there is some planning done, like linear accelerators is a good one. We have over 44 LINACs in our state. So it's quite a lot of LINACs. And you can't just go, oh, this one's full, I need a new one. You actually have to work out at what's the tipping point between too many patients and enough work to make the next one viable. And so we do that in our service planning work, and you expect the service to run at extended hours before you put in on the clinic itself, because anyone in cancer also knows that it's fits and starts in terms of referrals, and is that a sustained workload or not. Like every jurisdiction, the state doesn't have money to invest in resource that's then underutilized.
And there is also that thing, I guess, of turnover of equipment as well. So we know that the brand new linear accelerators are about 10% efficient. So there's those considerations as well. And that's why in Australia there is a general rule of thumb that linear accelerators life is 10 years. The same for bed. So that the expectation is that the technology is removed and that the newer technologies tend to be efficient.
Do you have any figures on radiation safety and incidents related to transport of radiopharmaceuticals, technetium generators, anything like that in that area?
We don't keep them in cancer, but the regulator would.
Right. Which regulator would that be?
The Victorian government regulator. We have a radiation regulator department.
Yeah, they're based within the Public Health Division.
Yeah.
Yeah. So Danny, isn't it? Yeah.
Would you hazard a guess as to how often there's been incidents?
No, I wouldn't. No.
Not in this room, no.
Well, for a start, you have to know the report, don't you? But assuming that they all are, no, I wouldn't hazard.
I mean, I think it's rigorous enough that they would be reported anything significant, like a spill or anything like that. Off the top of my head, they're incredibly rare.
They are.
Absolutely, and the other thing is, if they occur within a hospital, we have a great safety system for reporting incidents of all kinds, whether it's radiation related or not. But radiation incidents do go through that, and there is automatic pass through to the regulator for any significant incidents as well. And any contracts that we take with private providers to provide public service, they also have to abide by culture of incident reporting, including in the radiation space.
Any other questions? We can go a bit broader than cancer if you would like, but mindful. Got to get you out of here in 9 minutes, but
Outside of the Medicare rebates, does the state government provide additional funding for other diseases, or do you keep in that paradigm of what's on the MBS?
The state government, well, it depends what you're referring to. When you say treatment for, are you thinking of linac-based treatment or?
A PET CT, sorry, my apologies.
Right, okay. So if it's a PET CT in a public hospital, not all indications are funded by the MBS, as you'd be aware, but the public hospital might do a scan, which is therefore effectively funded by the state. So the state does contribute to some scans where they're not funded by the MBS. And that's particularly relevant in cancer because you might be saying lymphoma, there's a scan where you can have one per patient. That's completely inappropriate when you're trying to work out disease advancement or follow-up and so on. So that patient might get more than one, and we'll pick on Peter Mac because they've got multiple PET scanners. They have to suck up the cost of that subsequent scan. So in effect, the state government pays for that.
It actually has been quite a movement from the Commonwealth Department in terms of their approach to that. And so one of the last ones they did was the prostate cancer funding, which Cyclotron actually led. And there was a the stipulation was in biochemical recurrence at only 1-2 scans, already causing problems, enormous problems for the clinicians. But discussions with the Commonwealth Department recently is they're very much moving to let the clinicians decide which scans is mostly in the patient's interest. So they did that with breast cancer restaging, and the new public disclosure document about restaging and therapeutic monitoring so states that there won't be a limit to the number of scans because of the variables of patients' individual needs. It will be up to the individual clinician. So that's actually a really, really big step forward.
So I think that's a function of personalised medicine or personalised cancer treatment, where in fact, depending on your genetic status, now that we can profile them, you will save money if you give the right treatment as opposed to if you treat everyone the same. So it's a good outcome, you might say.
Yes, very exciting.
Different here.
Yeah, that's question.
Because this, I just wondering, I want to know about the diagnosis that it's done here. Like, for example, this diagnosis with PET scan is for someone that is not yet really known to have a cancer, so to detect in the early phase. So how do you do that? Do you do the screening for people, or is it from the patient or the hospital?
We only have very limited organised screening programs at a population level, so it's certainly not at a screening level. I don't know if there be any indications, so we typically have a diagnosis.
That's right. So we don't screen, no nuclear medicine scan is a screening scan in our state. You would do that once you had a suspicion of cancer. And particularly, of course, in the case of PET, it's particularly good for knowing as the cancer spreads. So you've usually got a positive diagnosis by some other means, you know, a CT or an MRI or something, and then you're doing a PET to work out the extent of disease.
Can I just say that with the new generation of extended field of view machines, like you just saw at MTIC, and we can get radiation doses down to a level that's equivalent to a 7 or 8 hour international flight. We think that there may in future be a role for PET scanning and screening, but that's very much in a research context, and potentially in areas where you have a lot of infectious diseases, and I don't know the status of TB in Indonesia now, for instance, but the FDG is not entirely cancer specific, and so there's a possibility that the screening programs may be confounded by that, even if we can show in a population where there's a low risk of infectious diseases that may be confounding, that it is actually effective and cost effective. But we think that it might be useful potentially in colon cancer screening with the new devices, given the waiting lists from the screening programs for colonoscopy. But that's research that has to be done.
So usually our programs for screening are actually decided at the national level. And then there's agreement across all the states that that's the way to go.
We've just finally got an announcement around lung cancer screening via CT. So that'll be the first step into a new screening program for a group of people who are more at risk. And that's going to be the next national screening program. Yeah, and using imaging. That's right. Well, imaging.
Oh, yeah, that's true. Sorry.
But first using CT for sure.
I heard common is the screening for the breast cancer for women is everywhere.
Yep.
Yes,
You have a lot of issues.
the main ones are breast, bowel,
And
Spinal, yeah.
Yeah, now we're adding lung
Rep-
from
reproductive.
2025. That would be implemented.
Luke, have we touched on everything you wanted us to touch on?
We just have one more item on the agenda, but that's a presentation. Colleague Stuart Bland. coverage of skills industry regions. Thank you very much, Helen. 5 minutes. No worries.
Okay, good afternoon, everybody. My name is Stuart Bland, leading Technology, Health and Sports within the Victorian Government. Today I'm representing both Global Victoria, which is the export agency of the Victorian Government to help Victorian companies, health and life sciences, for example, export internationally. So very close with those companies. All our life sciences companies coming together to connect with. On the other side, we've got Invest Victoria, which is an agency that the Victorian Government and international companies and organisations located and base themselves in Victoria and help facilitate those companies in a number of ways. So next slide. So about Invest Victoria. So there's a number of ways that Invest Victoria helps companies. We have free services support, including market entry, R&D capabilities, labour market skills and talent, and the cost of doing business. So information in all those areas. We have introductions to potential clients and partners in the market here, industry contacts, local suppliers. We help with site specification regarding planning and regulatory approvals as well, and access to different levels of government, including financial assistance to attract large investments into the state, and ongoing support to companies as well. So next slide. So we have 24 offices globally as the Victorian Government, so they're called Victorian Government Trade Investment offices. We've got 4 offices in Southeast Asia, as you can see, and they cover the 10 countries across Southeast Asia. So those offices deal with both trade and investment. They have teams in each city for both of these functions. They're responsible for investment attraction, trade, government relations, and education as well. Next slide. So these are our priority sectors, especially on the both trade and investment side. So you can see there, health and life sciences is one of those key priority areas, and the innovative technologies in these sectors are greatly involved in the state of Victoria, including infrastructure, precincts, waste, zero emissions. So next slide. So we've got a very supportive business environment here. We like to think that we're globally competitive. Melbourne's projected to be Australia's largest city as early as 2026. We have Melbourne's home to head offices of 49 out of the top 200 Australian stock exchange listed companies, and many international companies choose Melbourne for their commercial headquarters. Next slide. So here in Melbourne, we are a major tech city. 3,200 startups, at all different types of levels. 19 unicorns, so that's quite substantial in its own right, and we're helping a lot of those companies engage internationally because the market here in Melbourne, Victoria, Australia, especially the tech side, is not large enough to sustain, a growing and fast-growing business. A lot of the health and life sciences companies need to engage internationally and travel a lot. Next slide. So we're highly skilled and talent here in Melbourne, Victoria. We have over 271,000 tech professionals. That's estimated to be 370,000 tech workers in 5 years. We're ranked #1 student city in Australia and ranked #1 occupation for state nominated visas as well. Next slide. We have a world-class education system producing more engineer and related and technology, IT and business related graduates in 2021 than any other region in Australia or Singapore. Slide. My team in Invest Victoria want me to emphasise that Victoria has some of the lowest costs as compared to New South Wales and Singapore, and this slide shows that in terms of office space. This slide also goes further and compares a lot of the costs across the other states as well. Victoria. Slide. The Victorian tech ecosystem is a bit of a snapshot. I can talk about a lot of those individually and take a lot of time, but we deal as a Victorian government across all of these stakeholders, and we help companies through these stakeholders engage internationally as well. Next slide. These are some of our Victorian unicorns. I mentioned 19 earlier. So we deal quite closely with many of those companies. We're working with Telix Pharmaceuticals a couple of weeks ago when we had a Belgian delegation coming in. We did an event at the Peter MacCallum Cancer Centre with Telix hosting there. They've got an office in Belgium, and we're just creating those things as well. Slide. These are our active tech investors. Snapshot there. Breakthrough Victoria, as you can see up there, is relatively new. Breakthrough Victoria, $2 billion to invest into really highly innovative companies, and they've got a very experienced team there to analyse the technology, and as it says, breakthrough, so really highly innovative projects. This is an example of an e-commerce company that a lot of you may be well familiar with. The Victorian government's been working very closely with them. The technology hub that they'll be creating 65 full-time jobs over 5 years, and employ a team of 7 senior level engineers to focus on analytics, AI and R&D activities. And it's Indonesia's first listed tech unicorn. So just a little bit more on that one. In partnership with the Victorian government, Bukallah Pack will set up the technology hub in Melbourne to access Victoria's rich and tech and innovation capabilities, tap into the state's high quality pool of tech talent, and explore partnership opportunities with world-class Victorian universities. Next slide. This is how we can help as either Invest Victoria or the Victorian government more broadly, and these are some of the areas that I've mentioned earlier on for international companies looking at Melbourne, Victoria as location. Last slide. Thank you. This is more so from our investment team for Southeast Asia, but we've also got the Global Victoria team as well to help on the training side. So thank you very much. Any questions, please contact me.
Crazy comments I learned. Cole, just another question. Sorry to hit you. One of the dilemmas in Indonesia is transportation of radiopharmaceuticals, where it's a cyclotron and a PET camera, and the ability to transport is not regulated. Do you have any thoughts about how we do it here in Victoria? Because we distribute about 25,000 packages, and
we do distribute a lot, and it's a challenge where you've got a location, like we can fly things to more remote places, provided there's air services there. But a lot of it's actually by road transport, as you would be highly aware. Yeah. And so road networks are really good from that point of view, but that transportation is a challenge. But full stop. And one of the things that makes us think about, we talked about 21 PET scanners distributed across the state. We think carefully about where they're going and can we get the radiopharmaceuticals there, because obviously the longer it takes to get there, the hotter they've got to be become actually clinically useful for scans. So we build that into our sort of planning, if you like, around where facilities will go and what access they've got. Absolutely have to consider that as part of the package.
We're going UAV. We'll let you know about it.
Oh, hey, if a drone flies over and drops something, we have to now watch what it is.
Well, it gets it off the road.
I think the 25-kilogram pig dropping off the thing. I think that's going to do the most damage.
Unlike the Northern Territory, we haven't lost anything on the roadside as it's gone to its destination.
Or WA. Yeah. Yep.
Back to the investment and or the help. Yeah.
Go backwards.
The help. No, the help. Yes. It's no.
Fun. Back further.
Before.
Easy
About like help has 6 categories. 5 boxes.
5 boxes. That's right.
So this is the pharmaceutical health, biotech, vitamin, medical device, and medical platforms. So do you have any links with Indonesian industry on this groups and life sciences?
You know, I need to ask my in-market team around that. They hold a lot of in-market contacts. So like it's Jakarta, they would have the connections there, either on the investment side, on the trade side. There's several companies looking at Indonesia, Southeast Asia on the trade side. Our team in market would have connections into these companies.
So where, for example, Iran, the Jakarta office. So we use the Victorian government trade officer dedicated, whose name's Iran, to assist. So yes, the Victorian government's office is available to assist in multiple areas. And I think Hans, is there any other examples off the top?
Yeah, I think there's some companies also now connecting in with the Indonesian healthcare sector related on the Victorian level or in the state level. I think it's they're connecting. They're really doing a good job.
How about but herbal medicine, something like herbal.
Herbal medicine, natural products.
Yes.
Yeah, I'd have to work with my colleagues at Irwan Budianto market to get the more specific
It's quite strict regulation, isn't there, around?
Yeah, it's a mistake.
Yeah.
We'd like to stick to.
Yeah.
That's what I said. I'd be very happy to work with students and his colleagues in country to give you some further information on the
Yeah. We can have like a special webinars on this box. Yes.
You could go down in a lot more detail.
Yes, more detail on this issue.
I hope that's been useful for you. It's been delightful to have you here, and then hopefully we'll blossom further opportunities between Victoria and Indonesia.
Yes, I think for the Cyclotron and PET scan, I think we will learn more from Australia, because actually for the whole Indonesia we have only 5 PET scan, and compare here about 100 and something like that. Yes. So for how many Australian?
100.
No, how many Australian? How many million Australians?
25 million. 25 million.
We are 275.
Yeah.
Yeah, I think we have to work from this point and then look at the future using Australian experience.
Yeah.
Yes. Thank you very much.
No, thank you. Thank you for making time to come and see us. Thank you to those online. Teams.
Very appreciative. Thank you.
No worries.
So there should be some extra cancer plans just outside the door if anybody needs them.
to us.
It is for you. Thank you. It's our gift. Who's probably responsible?
It's
It's a big question. Oh, it also got some controls.
Yeah.
Oh, it is. Free now.
Pretty relaxed.
Yeah.